Uh, Now I would like to invite Dr. Prasanna Venkatesh Ramesh. He is MS Ophthalmology Gold Medalist, finished his glaucoma fellow under Dr. Satyan, and he has a degree of FAICO glaucoma, FICO glaucoma, and is medical director of Mahatma Hospital Private Limited in Trichy. He has numerous, around 100 public articles published in his name, and he is also a executive member in TNOA. Also has editor board of TNOA journal. I would like to invite Dr. Prasanna to give his talk on smartphone AI.
Yeah, thank you, Prithvi and Rajiv sir and the whole KSOS team for giving me this opportunity. So I'd like to start my presentation with a small demo of our innovation. So can we have the display, please? Yeah. So we like to show one particular innovation of ours, the augmented reality that we have recently innovated, and we have trying to revolutionize teaching, counseling, as well as surgical simulations. So yeah, can we have the screen? To add on to the smartphone clinic discussion, so we wanted to see how we can actually extrapolate more amount of technological evidences and use it maximum to smart teaching, smart counseling, as well as for smart simulative models. So one such thing I would see whether if it's working, or else I'll go for my presentation which I have it as a backup. Yeah, it's done. So can you just demonstrate the models, Tenzing? Yeah. You can see that many of us would have seen the Iron Man movie in Marvel, the Tony Stark, or the Iron Man, which we all see. Now you can see my friend here demonstrating the cavernous sinus. Many of us used to just cognitively mug up the anatomy of cavernous sinus. We never used to see how the transverse vein, the sigmoid veins all come and insert with each other. But now you see, my friend here seems to be demonstrating through thin air, but he is actually holding the patient's cavernous sinus and demonstrating it in real 3 dimensions with the hand-eye coordination. This, my dear friends, is what we believe will be the future of pedagogy. We don't need to really mug up the concepts, rather we can actually teach students what things are really are. Can we have the eyeball model tensing now? Yeah. Let's move to the eyeball model. Or the circle of Willis, yeah, we'll show the circle of Willis. Circle of Willis is, my dear friends, is again an undissectable structure. We never dissect the circle of Willis in our anatomy teaching. I remember in my days where I used to draw a pentagon, then draw a horizontal line, a vertical line, a lot of mugging up was there. But now this is a 3-dimensional structure which we sat with our anatomy books, drew the structure in 3D, and then we are trying to reconstruct it according to the patient's own case sheet. You can see that every anatomical part is there as 3D itself. You can rotate it. There is no blind spot as such. You get the structures as and when it is. And this is augmented reality, my dear friends, not virtual reality, because in virtual reality, the background is actually completely dark. In augmented reality, what we are seeing in the screen is what actually the person is seeing through his eyes. So this is next level cutting edge technology for surgical simulations as well. Can we have the eyeball? Yeah. So we all have anatomy classes. We have a huge difficulty to explain to undergraduates, postgraduates. In our models, we have used real fundus images. You can see the real optic disc, the macula. We have given a cross-sectional opening so that we can go into the eye, see the ciliary body, the lens, the zonules. And can we have an angle examination of the patient done now? Yeah. So this is like in telemedicine, we are trying to work on an EMR as well, where you can see that my dear friend is examining the angle structure. Not only the angle is seen in one particular frame of choice, it can be seen in any view. Can we have the side angle view and the magnified view so that the electron microscopic view is also shown? Yes. So now Mr. Tenzing here, who is also my research assistant, he's examining, see what is an angle recess. See, you can see the beautiful angle recess here, a scleral spur here, and all the electron microscopic band view of the trabecular meshwork. Yes. Can we have the simulation of the direct ophthalmoscope? Yeah. Yeah. Yeah, tensing, we just have a small glitch. Yeah, we are back. So this is the whole brain, the whole neural anatomy that we have also re-engineered or reconstructed. My friend here is actually, can you have the hand stationary like a direct ophthalmoscope? Yeah. Move into the eye. Yeah. So this is a direct ophthalmoscopy simulator where you can move towards the patient's cornea. You can come back again. Yeah, you can go back. Go back. Yeah, nicely go back. Nicely go back. Yeah. Now again go back into the eye. So these are some simple simulators that on day one of the curriculum, the students can actually be taught because it is hand-eye coordination. They see in reality what things are. Again, you can go back. Yeah, so this is the brain structure along with the whole eye that we have actually done, and we are trying to go back to even more. You can see the whole extraocular muscles. You can walk into the brain, show the dorsal pathway of all the nuclei. So the whole neuroanatomy is something that we have reconstructed, and this has been our baby for 5 years from now, and we have recently launched it in the market. So I'll just have my presentation now for the next 2 minutes to just summarize. So can I have the slides? So this, my dear friends, is augmented reality. We have virtual reality where the complete blackout is there and the opponent can never see what we are seeing. But with this technology, what we are trying to address is a simulative way of learning. What we see, sometimes our students may not actually see. Are you seeing the gonioscopy structures, or this is how the direct ophthalmoscopy has to be done? But they never tend to see exactly what we see through our eyes. But with this simulator that we have innovated, not only teaching, counseling, and for simulative models, we are trying to also inculcate into EMR as well as into telemedicine, so that even patient examination can be done as we are using real-time patient images. So how did this journey all start? Is the next few 2 or 3 minutes, I'll just take you through the mandatory slides, or take you through the pathway or cognitive way of how we actually innovated this. So my friend will be coming to each one of you. You can personally experience the touch sensation, what he is actually seeing through his eyes. Tensing, you can just show the innovation to all if time permits. Do you have a converter? Or HDMI converter? Yes. So what Iron Man or Tony Stark, many of us would have seen this, even in the Jeans movie we would have seen in 1990 Shankar, which was not thought to be reality. It was all thought to be science fiction. Is no more science fiction, my dear friends. We have innovated it in the field of ophthalmology, and my dear friend will be coming and you can all experience that in the place where you are sitting itself. We call it the 4D metaverse, which is a patent protected technology of ours, and we have a series of 6 smart innovations. We started with animations. What is a normal angle structure? What is a peripheral anterior synechiae? My journey started with animative learning. How can we make learning more catchy or more easier for the neophyte? We started making animative videos and then took them into real-time scenarios like an iris process and a peripheral anterior synechiae, as you can see here. Then we started making videos on short videos, 10 seconds, with less is more concept on why do we do a YAG PA? Because of the cause and effect. The cause is the pupillary block here, and the effect is the angle closure that happens here. So we wanted to make less is more in a single minute. Can we really give a concept which is very complex as glaucoma? This is one of my own videos where you can see the fundus of a patient. We just marked the cup and showed that the cup disc ratio is altered with increased vertical cupping. Then the video was slightly zoomed, and then you can see that the inferior notch is marked. Then we can go even more zoomed, and we can show the unspecific the bionetting sign, and then the basic signs is the ISNT rule. How is it actually breached? You can see that the inferior is lesser than the superior. Coming back to the RNFL, and always as a glaucomatologist, we like to correlate the structure with the function. have the same patient's visual field, and then have the OCT superimposed on the fundus and show how the RNFL defect is there, again in the OCT as well, followed by a mild ganglion cell layer, inner plexiform layer, thickness reduction. So this is a single minute video where we thought of taking on the challenge of making all complex pathologies in a single minute. As you can see, this is my YouTube channel which goes under my name. Many complex pathologies are delivered in a single minute for smart learning. So be it anything such as you can see here, an ALT or an SLT, the spot sizes are lesser in ALT, it's higher in an SLT. In oppositional angle closure, the dying out of ALPI, as you can see in this patient, an oppositional angle is relieved by an ALPI which is done in the periphery, causing the iris to pull back. The same can be shown in a front-down angle view where 24 spots are placed in 360 degrees. The same can also be shown in a gonioscopic view where the spot is delivered and you can see how the iris is being pulled away from the angle, relieving the opposition. Even basic concepts like removing the lens in a cataractous patient, you can see how the anterior chamber is deepening. You can see the fate of iris, how it falls back when the iris or the lens is removed. The fate of the ciliary body, how it slightly falls back when the cataractous lens is removed and an IOL is placed. A simple falling back of the scleral spur. This gives us good understanding about the primary angle closure glaucoma concepts or the release of the posterior, the peripheral anterior synechiae after cataract extraction. Then we started creating these models in 3D because we felt 3D animation is the way forward. Cavernous sinus, circle of Willis, the eye structures as a whole with real images. The one with our USP model of 3D was we went with real images, real fundus, real gonioscopic pictures as much as possible to have the photoreal effect which my friend is trying to come to your place and show. We also launched it in the Android platform. Nowadays the phones are equipped with augmented reality. You just need to download this app and you can just access it through buttons. You can click the anatomy and you can have a complete tunneling of full way in which your choice, how you want to go into the eye. You can choose anterior segment, go into the anterior segment. You can then choose the angle, you can go into the angle. This is like a button system, which was a very prototype model that we developed for the Android systems. And then you can see even that goes to the posterior segment as well. For want of time, I'll rush through and finish within a minute or so. You can see that we started using many pathologies. We started adding on autofluorescence, infrared, and the pathologies list kept on increasing. Flecked retina, fibrovascular band, retinitis pigmentosa. These are all our own patient data. Started collecting like an atlas. Any retinal pathology, any angle pathology, we started collecting. We had a Windows version of it, not only in the smartphone. The Windows version is also available. Then we also launched this in the Apple as well. You can see that a simple phone is actually showing the same model. The technology that we used to take a selfie with the spectacle glass or with the hat, the same technology we use to bring it into ophthalmology for teaching. We don't need to really know where the structures are. They can see it on day one and understand the anatomy as and when it is, and they can know it in real time. So this is again a phone display where you can see the structures that you are seeing in 4 dimensions can also be seen in your smart clinic and also be diagnosed, or even the patients can be counseled. This is again one of my glaucoma patients with a splinter hemorrhage, another patient with an RNFL defect that you can see beautifully in 3D augmented reality. Then this is the 4D holograms that we recently displayed. I'm just skipping it. It seems as if you're moving through thin air, but it is actually you are touching, you're feeling. You can actually move through simulations, and there are so many implications. We can learn SACS, phaco, surgeries through this augmented reality technology. We have also recently innovated a MIGS simulator which recently won the best poster award in the recently concluded Glaucoma Society of India. And then you can see that we can use many OCT filters. Practicing a hydrodissection and hydrodelination can be done with this technology. And this is my daughter here. The future generation children are very much equipped to this. I think this is going to be the future where it's going to be coming into the market. We are also 3D printing these structures. We are going back to the basics. We are using this technology to reinvent 3D printing for basic sciences. Like an automobile engineer, can we learn things like this? And we have also done this in the iPhone as well. The beauty about in iPhone is we have used subtractive learning. The structures that we don't want, we are actually removing it, and it is more like a virtual dissection. As you can see, the structures that we don't want, it's all separately removed. And I think this, my dear friends, will be the future in ophthalmic teaching and counseling. We call it the ophthalmic metaverse. And with that, I'll just stop for want of time. I'll just give you the last slide. And this is my team, headed by me. We are a team of 6 people, ophthalmologist and optometrist at Mahatma Hospital, Trichy. You can take a screenshot of this, my dear friends. These are the 6 innovations of ours, open access, currently readily available in the market. You can feel free to use it and share your feedback. And out of the 6, 5 are published in the innovation section in Indian Journal of Ophthalmology. One is currently yet to be published, which is the recent one. And we make a lot of images. The DreamCon image was made by us, which you would have all seen on the program book. And we make a lot of images. Imaging is what we specialize in, and I'm also a glaucoma specialist, so I have an inclination to glaucoma as well. Thank you once again, Prithvi and the entire KSOS team, for giving me this time to showcase on the smart innovations that we are currently doing. Thank you once again.